Thank you. First of all, I would like to thank Dr. Mehta and Dr. Bobet for the invitation and to give me the opportunity to be here with you in the first Presbymania Worldwide Congress. Okay, we can see. I will talk about presbyopia correcting bioptics, first of all, and then I will tell you about another thing. So the whole morning we are talking here about surgery for presbyopia, and we have talked about cornea and lens surgery, but no one of us has talked about scleral treatments. I think that scleral treatments are not really used nowadays. We are always talking about treating this at the cornea or at the lens. Why not bioptics? Why not to use the cornea and the lens approach? We have a problem with the presentation.
Slides. Yeah, the presentation is not here. Sorry for remote.
Okay, I hope
you can continue.
You can see the slides.
Yes? No? Yes? What does it say?
What we want to tell you is why not to use the bioptics? So to use a cornea procedure with an intraocular procedure with a lens. And that's why we have done. We've done it with a acrylisa lens plus LASIK. First of all, we made a complete ophthalmological examination. OSCAN and Pentacan was made, and IOLmaster. Then we need to inform the patient about the cornea surgery, but also about the lens surgery. We talk with them. Okay. About how will be the surgery with a multifocal lens that like the acrylisa, and how will it be like in a surgery with a LASIK procedure.
Good.
And also, okay, you can see the slides. We're in Switzerland, and also we can tell the patient that it takes time. It's like a Gruyere cheese. Usually I'm in Valencia, so I explain that it's like a paella. It takes time to be cooked and more time to be perfect. So be calm, because even that if we will use an intraocular lens like the acrylisa, which are very good technical features, with a hydrophobic surface, with a haptic angulation of 0 degrees, and with a very good diopter range from 0 to plus 32, even if we will have a good result with the acrylisa, we can have some small problems with the final results if we don't stay for a bit time. We will treat the patients later on, 3 months later, with an Allegretto LASIK. We talk about Allegretto wave light. Perhaps Monday we will talk about Alcon Allegretto. So that's why and perhaps in 1 year we talk about Novartis Allegretto. So it's the same laser. We make a small study with 20 patients who wanted presbyopia surgery, aged from 49 to 69, 8 men and 12 women. 6 of them were myopic patients, 9 hypermetropic and 5 emmetropic patients. We use mix 1.8 surgery, acrylisa always with an intracapsular ring, and 3 months later we make a LASIK to correct the residual refraction. When we use LASIK with the Allegretto system, we try to achieve, in these cases, a spherical Q of minus 0.5. Those were the results. Here you can see that first patient, for example, who is a myopic patient, has a pre-far visual acuity of 0.1, near visual acuity and correcting near visual acuity very good, And then after the surgery, we achieve a very good results. Results are similar, and we ask the patients about the satisfaction in this technique. We can say that the pre-uncorrected far visual acuity was, the post one was quite better, and the same thing for the near uncorrected visual acuity. And the satisfaction of the patient was 9.65. 13 patients needed LASIK. 65% needed LASIK. We are not, it's not clear for us if there's an advantage in these cases to use an aspherical approach in the cornea for the LASIK. But we are sure that LASIK improves the results, not only to treat some astigmatism, residual astigmatism, which is the problem that we have when we use mix, that we have the same astigmatism problem that we had before, but also because of this question that you've done before. There's a small differences between the results we wanted before with the Acrylisa, and even if the results for far and near are quite good, we need to improve the refraction final, and why not with a LASIK? What are we doing now? We are treating presbyopia with Bioptics. We're offering a new perspective. I will talk to you in the next presentation because we are trying to do a piggyback with Bioptics for patients previously operated, for those pseudophakic patients that we are talking also the whole morning. Thank you very much for the presentation.